Good afternoon. Thank you for joining us today. This is our last presentation in a series of 6, and all of them have been recorded. So if you missed any of them, you can go back and listen to them, or if there's someone in your practice who you want to have listen, they're all available for you to listen to. Today we're going to talk about OBGYN and eye conditions. And you say, now those are 2 odd chapters to put together. And they are a little odd to put together. But it was because when we looked at HealthFirst's list of members, we saw that we had provided some basic ICD10 education for everyone, but for the ophthalmologists, optometrists, and OBGYN doctors. So we put those together. This first section will be on OBGYN, and it's a high-level review. It's an overview of what you need to do. There are some key changes between ICD-9 and ICD-10 in terms of trimesters, and if we have multiple fetuses, how we indicate that. But a lot of what you're going to do in coding for OB for ICD-10 hasn't really changed that much. Now, I don't recommend this for physicians, but for coders, you want to look at the front of the ICD-10 book at the general guidelines. It's 30 or so pages long, and it has a section on coding for Chapter 15 for obstetrics. And when you look at it and you compare it with what it has in ICD-9, a lot of the characteristics, a lot of the rules and the principles have stayed the same. It's just that every single code has changed. So what we're going to talk about, we're going to do this high-level overview. We're going to talk about supervision of normal pregnancy and delivery, and then care of patients who have some condition, either maternal or fetal condition that makes them higher risk. Then we'll talk about examination codes in GYN and some common conditions in GYN. And GYN doesn't change too much for us, so we're pretty happy about that. So this is our chapter, Chapter 15, Pregnancy, Childbirth, and Puerperium. And you can see the list. All of ICD-10 starts with outlines. They call them blocks. I think of them as outlines. And you can see what we're going to talk about in this chapter. Supervision of high-risk pregnancy, patients with hypertensive disease. In 020 to 029, we have diabetes care. And then complications of labor and delivery, encounter for delivery, and then some complications related to the postnatal period. So supervision of normal pregnancy doesn't look too different for us from ICD-9 except for trimester. So supervision of normal first pregnancy, if it was the first trimester, we used Z34.01, and then you can see we have different codes for second and third. Notice that it says these codes should not be used with the code from Chapter 15. That means Chapter 15 is the code for obstetrics and delivery, for the care of the patient while they're pregnant and at delivery, and in the postnatal period. And this Z code is a status code. It's equivalent to our V code now. So we wouldn't code that the patient had supervision of normal first pregnancy and that the patient also had gestational diabetes. Those would be mutually exclusive in terms of their problems. And then Z34.8 is the subcategory code for encounter for supervision of other normal pregnancy. Notice we have unspecified for second and third. And then if we don't know whether it's the first or the subsequent pregnancy, we have encounter for supervision of normal pregnancy unspecified, and of course we do the unspecified trimester. Of course, we're going to try not to do those because we want our codes to be specific as possible. Let me digress just for a minute here, and I'm going to digress again about it when we get to the care of higher risk conditions or problems in pregnancy. Do we report codes every time we see a patient for a prenatal visit? Oftentimes we don't. Many commercial patients, if the patient starts with us and then delivers with us, we report one CPT code for the global package. And in that case, we wouldn't be reporting the supervision of the pregnancy. We'd be recording the delivery code. But often our managed Medicaid programs require us to submit a claim for each prenatal visit, or the patient might move from Tennessee up to Vermont in the middle of her pregnancy, and we would need to break out the codes or parts of the component package. And in that case, we would be reporting these codes. Z37 is outcome of delivery, and we're going to include this on all maternal records when a delivery has occurred. So what is it? A single live born? Were there multiple births? Were any of them stillborn? There are a lot of codes in this Z37 category of code, and that's where you find the outcome of delivery. So first we report the delivery, whether it was a normal delivery, which we'll see later on, or whether it was a patient who delivered and had an underlying complication, and then we report the outcome of that delivery. So again, the principles haven't changed a lot. It's just that every single code has changed. So the beginning notes, this is just briefly from some of those beginning notes that we find in the start of ICD-10. We're going to use the codes on the maternal record, of course. These are codes we wouldn't use on the baby's record. We use these on the maternal record. And some of the codes, we just saw those supervision of normal pregnancy, and when we talk about the higher risk codes, some of the codes are defined by trimester, and this is how they count the trimesters. Not too different than how we would count trimesters, but very specifically. So now I'm talking about the category of code O09, supervision of high-risk pregnancy. And there are a lot of different types of high-risk pregnancy that we would be including if that are included in this category. So patients with a history of infertility, ectopic or molar pregnancy, poor reproductive pregnancy, a young or an old patient, we would use a code from this category. So here we have supervision of pregnancy with history of infertility, and again, it's by trimester. So all of these codes now are divided into trimester, whether it's supervision of a normal pregnancy or a routine pregnancy or high risk. So by trimester, we have codes for excessive weight gain, recurrent pregnancy loss, like I said, a young or old mother, history of infertility, and then complications like infection, DVT, and bleeding. So here are just some examples. O09.611, supervision of a young prima gravida, first trimester. O09.292, supervision of pregnancy with other poor reproductive or obstetric history, second trimester. And again, we know we may, for some patients and some claims, need to be sending in claims either because the patient changes insurance or they have managed Medicaid, and these are the kind of codes that we would be using. So complications during pregnancy. So what was Category 648 in ICD-9 is greatly expanded. And if you've been listening in on these, then you've heard me say those words, greatly expanded, a lot over the course of the time. So for hypertension and diabetes, were they pre-existing before the pregnancy? And if the patient has diabetes, was it type 1 or type 2 diabetes or gestational, and then by trimester? And then if the patient has gestational diabetes, we also have different codes for diet-controlled or insulin-controlled, and then, of course, in pregnancy or childbirth or in the postpartum period. So here's an example of a code, supervision, pre-existing hypertensive heart disease, divided by trimester, and then look at the code that I have italicized. O10.12, pre-existing hypertensive heart disease complicating childbirth. So if you had a patient who had pre-existing hypertensive heart disease and gave birth, that's the principal diagnosis code that we would use. If you were still taking care of the patient and the patient hadn't delivered yet, then we would have the first, second, third trimester codes that we would be using. Here's a code for pre-existing diabetes. And you can see it's divided as type 1. And again, it tells us use an additional code from E10 to identify any other manifestations. And E10 is a diabetes code in the endocrine chapter. But if we have a patient who we're taking care of and we're during the pregnancy, who's got pre-existing type 1 diabetes, we're going to put down first, second, or third, and then when the patient delivers, 024.02. That's the code that we would then use. Multiple gestation, we already have some of this in ICD-9, so everything isn't new. The things that are really new are breaking up the trimesters, and when we get to multiple gestation, we have a 7th character for the fetus. So we have codes for twins and triplets. We have different codes depending on the number of placentas and amniotic sacs. And then some conditions, not all, but some have this 7th character extender for the fetus. So here's some examples. 031.21, and then we need an X. We need a placeholder code because I need a 7th character and I don't have a 6th. Continuing pregnancy after intrauterine death of 1 fetus or more, 2nd trimester, fetus 1. So we have very specific codes, and we pay attention to which fetus if the patient has multiple fetuses. Complications of labor and delivery, here is our codes for preterm labor, and it tells us it excludes false labor or threatened labor, and then preterm labor with preterm delivery. And this requires a 7th digit. So we would use a 7th digit even if the mother had only 1 baby, and that would be the digit 0. And how do you know that? If you're in your book, you go to the category code of 060, and it tells you, just like it does in ICD-9 when you need a 4th or 5th digit, sometimes it tells you 0 equals with and 1 equals without. It will say 0 not applicable, which means there's only 1 fetus, or 1 for the first fetus, 2 for the second. So here are just some examples of that, of where we have false labor, or preterm labor, and we've got trimester and fetus. And we would also be coding any complications specific to multiple fetuses. So if you've heard me before, I always joke, ICD-10 isn't going to be bad as long as we only deliver low-risk babies or give up deliveries altogether, or we don't do trauma. But if you are doing deliveries with high risk, and every OB doctor is, those are going to take us just a little more time to code now in ICD-10. Fetal stress, complicating labor and delivery. So we have by meconium, fetal stress in labor or delivery due to drug administration. And then here are more specific codes also in that category. Fetal stress, labor and delivery complicated by other evidence of fetal stress, and there you can see the types, or by unspecified. So if we're going to try not to use these unspecified codes, but sometimes we're going to use the unspecified codes because that's all we have. But here, you probably wouldn't need to, because if you had a patient who you delivered because of fetal stress or fetal distress, you would know what the type was, and you could choose a specific code. We have one code for encounter of a full-term uncomplicated delivery. So I've slightly abbreviated the description here under 082. So if you look at 082 in your book, it's got a few extra words to it. But it is the delivery requiring minimal or no assistance, with or without episiotomy, so you can still use this code if there isn't episiotomy, without fetal manipulation, that is, without rotation version, without instrumentation, no forceps, of a spontaneous, cephalic, vaginal, full-term, single, life-born infant. So if you have a nice, normal delivery, you would use this code, and you would use Z37.0, single live birth. If there were twins, we wouldn't be using this 082 code. We would be using a code for that indicated multiple births. There is one code for cesarean delivery without indication. So we're probably not going to be using this code that often, but 082, encounter for cesarean delivery without indication. And we would add a code for the outcome of the delivery. We had a single live-born baby. And when there's an indication for the cesarean, so you did the cesarean because of fetal distress or because the patient herself got sick or septic or hypertensive, then you use those more specific codes. So there's only one code here for this cesarean delivery without an indication. In terms of other deliveries, we're going to select the code that is in childbirth for the complications, and these sometimes describe the mother's condition and sometimes the baby's condition. I think most of that, if you're experienced OB coders now, you're probably going to find that pretty straightforward. And then we have preterm labor codes, as I showed you before, obstructive labor due to the position of the fetus. And then here's a code that we may be using, failed attempted vaginal birth after previous cesarean delivery. So this says this is the reason that we did the cesarean, Z066.41. Complications related to the post-antenatal period, to the postnatal period, we have sepsis here, and we're going to assign that a second code when we know the organism. And if it's severe sepsis, there's a code from the Signs and Symptoms chapter, R65. HIV infections, we have similar instructions here to the ones we have in ICD-9. So during pregnancy or childbirth, a patient admitted because of an HIV-related infection gets a principal diagnosis code from 098.7. And whenever I have a dash after the letter, or excuse me, after the number, we know that we're going to need an additional character. That's not a complete code, 098.7. There are other codes that we would be putting down. Patients with asymptomatic HIV infection status who are admitted get that same code, 098.7, and a Z code, a status code, Z21, asymptomatic human immunodeficiency virus infection status. So we report that to the payer. Alcohol and tobacco abuse or use stay about the same. We use 099.31 for alcohol use complicating pregnancy, and then a secondary code from the mental health chapter from the alcohol-related disease disorders is used from F10. And then for smoking status, if we have smoking complicating pregnancy or childbirth or the puerperium, we use 099.33, and then we're going to add another code from the F17, that's a mental health code, nicotine dependence. It's equivalent to a code like 305.1, or tobacco use, we can use a Z code. So that, again, is fairly similar. We have a patient who delivers outside the hospital. We have a diagnosis code for that. Now, routine exams in ICD-10 get a little bit of a change. If you listened into some of the earlier presentations, you may have heard about this, but if this is the first one you've listened into, then you probably didn't. But routine exams in ICD-10 have with or without abnormal findings. So we're not going to just select the equivalent of V7 2.31. We're going to have a code for a GYN encounter with or a GYN encounter without abnormal findings. There's greater specificity. We saw that in terms of the trimester for prenatal care, and that's for uncomplicated prenatal care and high-risk prenatal care. And we have one code for immunizations, so that makes it a little bit easier. So here we have our two codes for GYN exams, Z01.411 and Z01.410. An encounter for a visit, a well-woman visit, but now we're going to use a different code depending on whether it's with or without abnormal findings. And the guidelines say it's abnormal findings at the time of the visit. You don't have to wait for the pap smear to come back in order to code this. And we code first this examination code. If it was abnormal, we would be coding Z01.411 and counter with abnormal findings, and we code second the abnormal findings. So I would use this if the patient had a mass in their abdomen that you discover, an ovarian cyst somehow that you notice, a breast mass, some abnormal finding on the physical exam at the time of the well woman visit, and then we code the abnormal finding exam code first and what the finding was second. And again, you don't have to wait. And how do I know we don't have to wait? Because I read the general guidelines in the front of the books about examination codes. And the general guidelines aren't for our physicians. We're not going to torment them and ask them to read them, but we as clinicians are going to glance through them all and pay particular attention to the ones for the to the organ systems and diseases that we use the most. One code for immunizations in ICD-10, Z23, Encounter for Immunization. And there's a note, so if I turn to that page in the book, to Z23, it has a little note that reminds me, code first any routine childhood examination. So that means first we're going to put down the well visit or the well woman's visit, and then procedure codes are required to identify the types of immunizations given. So we're going to use our CPT code to show the type of immunization that we gave, flu shot, zoster, whatever the immunization was that we gave, and the administration codes. And of course, if we get the vaccine serum for free, if there are any that we still get for free from the state, we can still report those, and people usually put a 1-cent charge down with that. Okay, so how about some other codes that we're going to use frequently? We have some other screening and special circumstances codes. So, and I put the ICD-9 code on the left and the ICD-10 code on the right. Some of these are one-to-one matches, essentially, but the description has changed. So when we think about ICD-10 and we're going from about 14,000 codes to about 70,000 codes, we know we can't have a one-to-one match. And you can imagine if you were trying to get a one-to-one match between the OB codes, the care of the patients with high-risk pregnancies, you could never get them to match because each one would go to at least 4, first, second, third trimester or unspecified. But about 25% of codes match one-to-one, and about 24% of those 25 have a change in the description. So here's some examples. Screening for other, encounter for other screening for malignant neoplasm of the breast, Z12.39. Screening for anemia gets a code that is less specific. Z13.0, encounter for screening for diseases of the blood and blood-forming organs and certain disorders involving the immune mechanism. So it's a little more inclusive than the equivalent of V78.0, screening for iron deficiency anemia. There's no more specific code in ICD-10 for screening for iron deficiency anemia. Screening for malignant neoplasm of the rectum is a nice one-to-one match, Z12.12, and pregnancy state incidental, V22.1, goes to Z33.1. And I think in OB you probably don't use pregnancy state incidental as frequently as some other specialties, because another specialty would be treating something else and then just saying, well, this patient is pregnant. But you could be using that code if your patient came in with a bronchitis in pregnancy, and they came to you because they're pregnant and they want to make sure that they are seen by someone who understands about their pregnancy. So you would use a code from the respiratory chapter, a J code for the bronchitis, and then you would say pregnant state incidental. So there, although you wouldn't be using that code as frequently as some other specialties, there are still some circumstances when you'd be using it. Contraceptive counseling, we have a general counseling code, Z30.09. insertion, removal, and surveillance of an IUD. We have the same kind of codes that we have in ICD-9, but of course there's Z codes now. And then here's an example where we don't have quite a specific code in ICD-10. Z25.5, surveillance of implantable subdermal device, really just goes to encounter for surveillance of other contraceptives. There's no more specific code for that. So now I'm just going to show you some ICD-10 codes from the genitourinary chapter. So we were in O, we were in our chapter related to pregnancy, and the next chapter, chapter 16, oh no, that's not the next chapter, it's the chapter before. You see, I don't know my alphabet. It's a good thing I don't still work in the office and have to file things alphabetically. Chapter 14, diseases of the genitourinary system, N00 to N99. These codes are pretty easy compared to ICD-9. We're not going to have a lot of trouble either matching them or finding them. So I'm not going to read them to you. I'm just going to show you some of these codes. And they many of them are a one-to-one match from ICD-9. So first we had scant menstruation. Now we have excessive, frequent, and irregular menstruation. Excessive bleeding in the premenopausal period. So we have those. Those, I think, are not going to give us too much problems. And then other problems related to the menstrual cycle. Vaginismus, pain, dyspareunia, those are pretty straightforward for us. And finally, we come to just a few other codes from the N94 categories that, again, I think are going to not pose too much of trouble to us when we go to code those. So, Holly, I seem to have finished a little quicker than I had anticipated, and I'm ready to open up the phone for questions.
Great. We have just a couple questions so far, but I encourage everybody to ask more questions because we do have some time for that. The first question we have is, should we code Z34 for routine OB visit with a complication code like gestational diabetes?
So that we don't do because those are, in essence, they're like mutually exclusive codes. So if the patient has a condition that is high risk, that is equivalent to our 648 codes now or other ICD-9 codes, then we don't code the either the normal delivery code, the 082, and we don't code the normal supervision code in the Z34 categories of codes. So it's really one or the other that we end up coding.
Okay. Our next question is, would an OB practice ever use the incidental pregnancy code? I think you covered that, but it sounds like someone's looking for some clarification.
So I do see this code used, and we wouldn't use it when the intent of the visit was either supervision of normal pregnancy or supervision of high-risk pregnancy. And I wish we were together so I could ask you this question. Do you ever get paid for extra visits during the prenatal period? So if we were thinking about CPT, we would open up our CPT book at the front of the maternity section, and it would tell us what's included in the maternity package. And it's actually not a certain number of visits. It's a number of visits per time period. So one visit for a certain number of weeks, and then biweekly visits when the patient reaches, I can't remember how many weeks, and then weekly visits at 32 weeks, I think. So it's not that we count up how many it is. It's that if we have a patient who's in a period where we expect to see them once a month, and instead you see them every other week because they're high risk, do we get paid for those extra visits? And some groups wait until the end to bill those after they've billed the global. But I think you have almost zero chance of getting paid for them if you wait until then. So I think those extra visits that we're allowed to get paid for, either because the patient has a complication or because we have some other condition that we're treating, my opinion is we should try to bill those at the time that we perform them. Then if we're seeing the patient because they have hyperemesis or they are a gestational diabetic and we're seeing them more frequently because of that, we want to make sure that we're using these specific codes that describe the complication or condition. Sometimes I see those extra visits billed with a normal pregnancy code, and that's never going to get paid. So if I'm seeing the patient, I should say I. If you're seeing the patient and it's extra visits for a complication, then we're going to use the complication code for our diagnosis, and I think try to bill it right away. But if you're seeing the patient for bronchitis or asthma, and they've come to you because, or a terrible rash, and they've come to you because they're pregnant and they don't want to go see their dermatologist, and actually this happened to me during pregnancy so many years ago I don't want to admit it, but I was dog sitting for a dog, and the dog rolled in poison ivy, and then I touched the dog and I got poison ivy all over the sides of my arms, and I went to see my gynecologist. The gynecologist should have billed me for that visit extra, because that wasn't part of my maternity package, and used poison ivy as the primary diagnosis code and pregnancy incidental as the secondary diagnosis code. I have no memory, of course, of whether she did that or not, but that would have been the correct coding for that. And it's the correct coding whether we're using ICD-9 diagnosis codes or ICD-10 diagnosis codes. Holly?
We have one last question today, and this is, I think, a good one for both of our sessions today. I received an email alert that CMS isn't going to deny claims if the ICD-10 code is not specific. Do we still need to worry about right and left? What about other payers?
Oh, you know, I've been talking about this with my fellow colleagues ever since this hit. And this hit yesterday morning. It was an announcement from the American Medical Association and CMS. And they said specifically, well, they didn't say too much specifically, but the AMA said, you know, due to our advocacy, CMS has agreed to give physicians a grace period for a year and has promised that the MACs won't deny codes that are unspecified, and the RACs won't review and penalize you for codes that are unspecified, as long as you are in the correct family of codes. So that was the first thing, and I'll tell you about the second thing that they said as well. But when I read that, I got a little pale, because family of codes is not a concept in ICD-10 or ICD-9. In ICD-9 and ICD-10, we have category and subcategories of codes, but there's nowhere that I can find the word family of codes in the general guidelines for ICD-10. So I don't know exactly what they mean. I mean, family of codes is a CPT concept. I can start with colonoscopy with the base code, and then there are a related set of family of codes. So I understand why the AMA is thinking about it in terms of family, but I don't understand why Medicare, which of course understands ICD-10 codes, is thinking about it in terms of family. So that's the first thing. They talked about family of codes, and I'm not sure how to translate that into category and subcategory for ICD-10. The second thing is, what this doesn't mean is that they're going to take an incomplete code. So thinking back to the basics of ICD-10, a complete code can be 3, 4, 5, 6, or 7 characters long. When I talked about 0 to 4, it is a category, and it is diabetes mellitus in pregnancy, childbirth, and the puerperium. And then I need a 5th character, actually. It isn't even enough to go to a 4th. So I have my category code of 0 to 4. I have a subcategory code of O to 4.0, type 1 in pregnancy, and that requires a 5th character, so the complete code is 5 characters long, 024.011, excuse me, 6 characters long, 024.012. So what they're not saying is we're going to start accepting 024 or 024.0, which are incomplete codes. And most of our software systems wouldn't let us submit that code incomplete as either. So we're going to have to submit a specific code. So as I think about what that means, I assume it means I'm allowed to use the code that ends in unspecified trimester if I needed to. I don't know why I would need to, but so I have these 4 codes in the 024.011, 012, 013, 014, 019 for first, second, third trimester and unspecified trimester. So I assume they're saying we're not going to deny the unspecified codes. Personally, in some areas, it's going to be just as easy to pick the right code as to pick the unspecified code. You almost have to go out of your way to do it. In other conditions, it may take more work to get to the more specific code. So that's the first thing Medicare said. The second thing they said was that if the MACs are having trouble paying, that they'll they won't let physicians' cash flow suffer from that, that they'll advance some money. And some of the MACs have done that before when there was trouble with enrollment, when they went from one MAC to another. One commercial insurance company took over the MAC payments from another, and the enrollment files didn't come over. They advanced physicians based on their typical Medicare payment. So Medicare has agreed to do that. What other private payers are going to do, I don't know. And the thing that I always say or have been saying is almost any ICD-9 or ICD-10 code gets you paid for an office visit. It shows the medical necessity for the office visit even if it's unspecified. We don't see a lot of denials for that. But for ordering diagnostic tests, for doing a procedure, I would think they would want the specific code. Certainly the private payers, I would think, would want the specific code if they're requiring it now. I think they're going to require it in ICD-10. But now that Medicare has given us this leeway, honestly, I think it just makes things more confusing. But I think we're going to have to watch the press in the next couple of weeks and see what the clarification about that is. So, Holly, I was a little long-winded about that, but it has all of us kind of buzzing away.
Well, there's actually a follow-up question to that. Do you have any indication that this means that CMS will deny unspecified codes after 1 year has passed?
That's a really good question. I am not, this is the way I think about that. If they are denying your unspecified codes now, they will deny them in the future. And they are likely denying them when you are ordering a test or doing a procedure. That's when they do it. But if they are not denying them now, I don't think they're going to start denying them a year from now, but I could be completely wrong about that. And if you're already seeing medical necessity denials, you'll certainly see more of them when the payers begin doing that.
Great. This is the end.
Holly, are we ready to switch gears?
Yes, this is the end of our first part of the session. Anyone who's on is welcome to stay on and talk about ophthalmology or to hop off the call. And
years, leave behind the mothers and the babies and talk about diseases of the eye and the adnexa. So this is Chapter 7. There are many fewer changes in this area, although there is one huge change, which is laterality. Diseases of the eye used to be in the nervous system chapter in ICD-9, but it's been moved to its own chapter in ICD-10, and it was diseases of the nervous system and organs, and sense organs. And so eyes got their own chapter, and ears got their own chapter too. But there are not so many changes in this chapter. Laterality, as I said, is the big one. There's a change in glaucoma. There's a term change in terms of cataracts that we're going to hear about. And then if you've heard any of these others, I'm going to tell you injuries are going to hurt. I'm going to talk just a little bit about injuries and complications, which are a little different from what we have in ICD10, ICD9. So common conditions we'll review, laterality, and trauma. So here are the blocks, the table of contents for ICD-10 for this chapter. We've got the eyelid, conjunctiva. You can see it goes down in pretty reasonable order. And notice I'm going to talk about this at the end, H59, intraoperative and post-procedural complications of the eye and adnexa not elsewhere classified. One of the major changes that we had in ICD-10 is that complications from procedures, which were all in one spot in ICD-9, in the 9-9 series of codes, they are moved into different places in ICD-10. So if you have had an eye operation and there's a complication or post-procedural problem, the code for that is in the eye chapter. If you've had a digestive system surgery and there's a complication from that, the code for that is in the digestive chapter. And then there are some codes in the trauma chapter, adverse effects essentially, for sepsis, when the complication isn't related to simply to the area of surgery. And we'll see an example of that too. Okay, so glaucoma. Glaucoma is a little different from ICD-9 to ICD-10. We have combination codes that identify the type of glaucoma, laterality, and stage. If the patient has bilateral glaucoma, and it's the same stage and type, we get to report one code. But for bilateral glaucoma, where one eye is either a different type of glaucoma or a different stage of glaucoma, we would report two codes. So that's because we didn't have laterality before. This is a little bit different. So here are a couple of examples. H40.011, open angle with borderline findings, low risk, right eye. So we know if we have right eye, we'd have left eye, bilateral eyes, and unspecified eyes. H40.043, steroid responder, bilateral. H40.051, ocular hypertension, right eye. So I don't think those are going to cause us too much problems. But then some glaucoma codes have the stage built into them. So when we go to the H40.1 to the H40.6 subcategory of codes, those codes require a sixth character for stage. Excuse me, a seventh character for stage. So, and again, how do we know that? If I have my book open and I go to the subcategory code H40.1, there's a little pink box, and it says one of the following seventh characters is to be assigned to each code in the subcategories, and then it lists the categories, the subcategories for me, to designate the stage of glaucoma. 0 is unspecified. We would try not to use that. 1, mild, 2, moderate, 3, severe, and 4, indeterminate. And unspecified is when we're coding and we don't know what the stage is because it's not in the documentation. And for some reason, we don't query the provider. That's unspecified. Indeterminate is when the physician doesn't determine the stage. So H40.122, low tension glaucoma, left eye, it requires a seventh character. And we'll change that, by the way, on the handouts when we post these so that you have it correct. Requires a seventh character for the stage. If you're in your EHR, of course, then you're not looking in a book to see this little pink box at the top of the subcategory of code. But your EHR won't let you select a code that isn't complete. So if you tried to use H40.122, it wouldn't let you. It would give you the choice of 1220, 1221, 1222, etc. It won't let you select a code that is not complete. If you're still on paper, we've talked before about a resource for you online, which is ICD10data.com. The initials ICD, the number 10, data, DATA.com. And so if you're not using an EHR and looking up your codes in your EHR, take a look at that program. It's going to be easier to use than your book. So we've got these stages in these categories, glaucoma codes by the type, by laterality, and they're all going to require that 7th character for stage. I was trying to abbreviate those codes. Now how about cataracts? Cataracts don't have many changes. Laterality is the biggest change that we have when we're coding for ophthalmology. Not all codes have laterality, but most of them do. So one change that we have in ICD-10 is the term change. Age-related cataract is replaced by senile cataract, laterality. Hypermature cataract, that term is replaced by Morgagnian-type cataract. And then in ICD-9, we have some specific codes that become less specific in ICD-10. You'd think if they were giving us 70,000 codes, we could be specific, but here's one. H25.89, other age-related cataracts is a code that you might have a more specific code for now. There are a lot of similarities between ICD-9 and ICD-10 for cataracts, but with this addition of laterality. So we choose the type, combined forms, incipient, and then incipient you can see is broken up just as it is now into anterior subcapsular polar, cortical, posterior subcapsular polar, other incipient type, Morgagnian type, nuclear, and then other specified type and unspecified type. We're going to try not to use the unspecified types whenever possible because we typically know the type, so why wouldn't we use it? So here's some examples. H25.11, age-related nuclear cataract right eye. And we know, you can tell what else we have by the examples just by knowing how ICD-10 works. So if I go to my book for H25.11, I've got unspecified eye, right eye. H25.11 is the right eye, but H25.1, that subcategory, has unspecified eye, right eye, left eye, and bilateral. So we get those 3 choices all the time. H25.012, cortical age-related cataract, left eye. H54.043, posterior subcapsular polar age-related cataract, bilateral eyes. And if you had a different type in one eye than the next, you would do both. All of the codes have laterality and increased specificity when we have lids. So here we have an allergic dermatitis. Is it the right upper, right lower eyelid, or an unspecified lid? Is it the left upper, left lower, or an unspecified eye? And we even have a nice, really unspecified code at the bottom. Allergic dermatitis of unspecified eye, unspecified eyelid. Of course, we would try not to use that. Notice that there's no bilateral code for this condition. If there's no bilateral code and the patient has the condition on the right and on the left, we code them both. So if this patient had this allergic dermatitis of the right upper and the left upper, we would code both of those codes because we don't have a choice for bilateral. So not all codes have a choice for bilateral. Most of them in the eye chapter do, but not all of them. Here we have laterality for the dry eye syndrome, right, left, bilateral, and unspecified. So there's an example of where we do have both codes in the system. Now, conjunctivitis, One of my mantras about ICD-10 is if it was unspecified in ICD-9, it doesn't get any more specific when we go to ICD-10, unless you worked at it, of course. So the equivalent of 372.30, or the conjunctivitis code that we use, when we try to cross that or look that up, that gets us to an unspecified type of conjunctivitis and unspecified whether it was right, left, or bilateral. When I look at H10, the category of code that is conjunctivitis, I have a number of different types, and I also have acute and chronic. So for acute, I have mucopurulent, and that's divided even farther into acute follicular or other. I have acute atopic, acute toxic. So the type of conjunctivitis gets much more specific. And then, of course, you have left, right, and bilateral. Is it serous? Is it unspecified, which we're going to try not to use? And then we have chronic conjunctivitis in the H10.4 subcategory of code. When we're coding these, if we know the type that it is, it just makes sense to go ahead and code them as specifically as possible. And here's where, and we were talking about this over the last 5 or 6 weeks, here's where a paper encounter form doesn't help you anymore, and where a cheat sheet or a conversion from 9 to 10 doesn't help you. Because if you have a one-to-one match, or if you're use a very limited set of codes, you may still be able to use that kind of a tool to help you. But mostly, anytime we were using codes that were too unspecified in ICD-9 anyways, we might as well at this point get rid of those paper tools, those cheat sheets that we have, and start by looking things up. And let me talk for a minute just briefly about mapping versus looking something up. If you're mapping from an unspecified code, you're better off starting fresh and typing the term into your search box and searching down through the lists that you have, because it's going to be quicker for you. Whereas if you're typing from a pretty specific code in ICD-9 and you're going to try and map or translate that into ICD-10, you may only have a few codes displaying that you're going to select from. So we're going to need to get rid of our paper encounter forms. They're not going to serve us well. It's going to be all unspecified and non-specific codes if we use them, and particularly where every condition that we had before is going to at least right, left, and unspecified, or right, left, bilateral, and unspecified. There are just too many codes for us to do that. H35 is the category for other retinal disorders. H35.01 dash. The dash tells us we're going to need another character. Changes in retinal vascular appearance, or dash 02, exudative retinopathy. And of course, there are many different types of retinopathy that we have the choices of both in ICD-9 and in ICD-10, and we want to make sure we're using the most specific one possible. We have non-diabetic proliferative retinopathy, unspecified eye, right, left, or bilateral. Visual disturbances. Notice that all of these codes have this nice dash behind them. And what that's telling you is that that's, of course, not a complete code. So if I look at amblyopia in the H53 .0 dash subcategory of code, I'm going to find other choices. It's not going to be just one code. It's going to be by type, unspecified, deprivation, refractive, strabismus, and then, shockingly, by laterality. If I look at diplopia, I get the same kind of thing. What kind is it? Oh, I beg your pardon. Diplopia has one code, and that shouldn't have a dash there. It is double vision. H53.2 is a complete code. We're always happy when we have a complete code that's short like that, aren't we? Rather than a big, long 7-character code. That might be a code we would even be able to memorize as we're working in ICD-10. Blindness. Blindness gets a little complicated. One eye unspecified. Is it right eye normal vision, left eye blind? You have there are different codes depending on whether the patient is blind in one eye or both eyes and which eye is which. So those might take a little extra time to code in ICD-10. Now let me talk about complications of procedures, because this is something that changes significantly from ICD-9 to ICD-10. So some of these codes are moved to the back of the chapter that we're working in. So in this case, they're moved to H59. Some other more systemic codes, like sepsis, some postoperative infections that are more systemic, are in the chapter with trauma, because the trauma chapter is actually called injury, poisoning, and certain other consequences of external causes. But most of the complications that you would be working at would be at the end of chapter 7 for the diseases of the eye. And these include complications of eye procedures, intraoperative and post-procedural complications. If we have hemorrhaging, hematoma, post-op, here I have an example here of a post-op complication following cataract surgery, keratopathy. If you have a lens fragment, a macular edema, or other disorders following cataract surgery, there are specific codes for that. And H59.012 is one of them. Keratopathy following cataract surgery, left eye. We always know if we have something with the left eye, we have right eye and bilateral eye and unspecified eyes. So there's a whole set of those, and that's where you find those. And they're more specific than they were in ICD-9. So in ICD-9, we had more general type categories and subcategories than we have in ICD-10. Here's another one, H59.111, intraoperative hemorrhage and hematoma of the right eye and nexa, complicating an ophthalmic procedure. So when we have an intraoperative hemorrhage, we know we're also going to have some codes for postoperative hemorrhage. So if we have a post-procedural hemorrhage, there's a different set of codes for that in the H59.31 subcategory. We have codes for accidental puncture and laceration of the eye and adnexa during a procedure, and whether it was an eye procedure or another procedure. So these codes we're finding in this chapter. We would use an appropriate, sometimes we might have a CPT code that went with it and sometimes not. It depends on whether you were just seeing the patient or whether in the post-op period and not submitting a claim or not. So would we be reporting these codes? Let me talk about that. If we were not submitting a claim, we might be selecting one of these codes in the system in our EMR, but we wouldn't be submitting this code to the insurance company or to the payer because we're in the post-op period. And for most payers, complications related to the procedure are included in the post-op period. Certainly for Medicare, they always are. So whether you're actually going to use these codes or not is going to depend on what you're actually doing. Are you doing a procedure related to one of these codes, or are you just watching and seeing the patient for extra E&M services that you're not reporting anyway? If you're in the hospital, you know the hospital is going to be reporting these services, those diagnosis codes. So let me talk about injuries now. If you listened in on the trauma one, you'll know that I say injuries are going to hurt, because injuries and foreign bodies are in the trauma section, and that includes injuries to the eye, or foreign bodies into the cornea are in the trauma section. They are more specific in terms of location. They have laterality, of course. And then they have a 7th character extender that tells whether this was the initial encounter when you saw the patient, a subsequent encounter, or a long-term after effect. Many of these also are with or without foreign body. And again, that isn't like it's anything new to us, a new concept from ICD-9. We've had with and without foreign body in ICD-9. It's just that we get more of it in ICD-10. There's just more choices, and specifically about locations. So locations get more specific in ICD-10. So let's talk about this 7th character extender. If you listened in on the trauma one, you already know about this. But an injury requires a 7th character extender. If you're treating a fracture, so a fractured orbit, then you're going to have more choices for your 7th character extender than these 3. But most of the injuries that you're going to treat are going to require one of these 3. And the 7th character always goes in the 7th position. So if you have a code that only has 3, 4, or 5 digits, you may need a placeholder X code to get to that 7th character. And you may see that placeholder X code in your EMR if you're looking up a injury code that doesn't have enough characters to get you to that 7th position. And I'll show you one of those. So here they are. A is the initial encounter used when the patient is receiving active treatment for the condition. And everyone can use this A. It isn't about initial or established. It's the first time you see that patient and during the period when you're actively treating them for the condition. D is for a subsequent encounter, routine healing used in the recovery phase. And a lot of times, just as I mentioned with that other post-op complication, a lot of times we wouldn't be submitting a claim for a service for the subsequent encounter because currently that'd be part of the post-op period. And then S is for a long-term after effect. It's a complication or condition that arises as a result of that condition, and there's no time limit on this. So if the patient comes in and says, I have had eye pain ever since you did that cataract surgery 4 years ago, then we would use the code for the cataract, injuries, I'm misspeaking. A patient who comes in and says, I've had eye pain ever since you removed that foreign body from my eye, from that cornea 4 years ago, we would use the trauma code for the corneal abrasion with the S code for the condition, on that condition to say that this was a long-term after effect. So these are new 7th characters to us. It's a new concept, and they're explained in a little more detail in the front of the ICD-10 code book in the general guidelines. And just remember that the A is not to be confused with new and established. It's the initial encounter. So the ED doctor, the ophthalmologist, the primary care doctor, if all of them were seeing the patient for this injury, would all use the A on their diagnosis code for the first time that they treated the patient for that condition. And a patient who had a condition over the weekend and was treated in the ED and now came to you on Wednesday, when you saw that patient the first time on Wednesday, you're going to use A in your 7th character. So here's some examples. S05.01XA, here's an example where we needed a 7th character extender, and we put that X code in there, injury of a conjunctiva and corneal abrasion without foreign body, right eye, initial encounter. So I'm going to end here by talking a little bit about refractions and some about vision exams. So here's my mantra. If it was unspecified in ICD-9, it's going to be unspecified in ICD-10. And you're going to be able to cross it to an unspecified code. But if you have the option of, instead of crossing it to an unspecified code, of choosing a more specific code, that would be the better thing to do. And it's easy, and I say this as a person who's working around in both the program and in the book, it's easy to get lazy about mapping codes rather than looking them up. And here's an example where I think we would be better served if we had 367.9 not to map to H52.7, unspecified disorder of refraction, but to go to the disorders of accommodation and see what kind of problem it is. And now we know if we do that, we're going to have codes for right, left, bilateral, and unspecified. So that would be the better thing to do than to just cross to this unspecified code. So for refraction, we have laterality for most of the codes. So H52.1, myopia, when I look at that, is it hypermetropia or myopia, and is it right, left, or bilateral or unspecified? For astigmatism, is it unspecified, irregular, or regular, and right, left, and bilateral? Presbyopia, single code, complete. We're happy about that. We're always happy when we have these single codes that we can find where we don't have to go to any more detail. Vision exams are like other exams in ICD-10, where we have the exam code broken up into with or without abnormal findings. So a patient who comes in for a vision exam and there is no abnormal finding, we use Z01.00. If they have an abnormal finding, Z01.02, and we use an additional code for the abnormal finding. So that is a change that we find in all of the examination codes in ICD-9, in ICD-10. So that is a real significant change. So Holly, we are going to open up the phone for questions, or if we have any questions that have queued up, I'm ready for those now.
Great. We have just a few this morning. First is, would a patient with a corneal foreign body, do we need to use a 7th character for the code?
Yes. So the way I would find that, if I were online, I would go to corneal foreign body. If I were in my CPT, if I was in my ICD-10 book, I would go to the index and probably go to foreign body. Some of you are probably so much faster in your indexes than I am, but that's what I would do. Of course, it would help if here we're doing ophthalmology, if my eyes were better and I could see these. So I go to foreign body, and then I get to cornea, and it sends me to T15.0, and it has a check mark behind it. So it's telling me this is not a complete code. You can't just code. We never code from the index anyways, but it's telling me this isn't a complete code. So I go to T15 category, foreign body in external eye. Right below that category of code, I have a pink box that says the appropriate 7th character is to be added to each code from category T15, and it gives me those 3 7th character extenders: A, initial encounter; D, subsequent encounter; S, sequela. And then I have a code for foreign body in the cornea, in the conjunctival sac, foreign body in other and multiple parts of the external eye, and then a note, foreign body in lacrimal punctum, and then foreign body on external eye, part unspecified. We don't like that. And then each of those 4, cornea, conjunctival sac, each of those 4 has unspecified right, left, and, unspecified right and left. No bilateral code here. If I had a foreign body in the cornea of the right eye, the code is T15.01. So that's only 5 characters long. I need a 7th character, so I have to insert an X there. And then for the initial encounter, I'd get the A. So these injury codes are in the back of the book. They're not in the I chapter, just like they are in ICD-9. And then some of them are in S. Those typically tend to be these chapters are organized. The injury chapter is organized from the top of your head down to your body, organized anatomically. So superficial bodies of the eyelid are going to be in the S00 categories. eyelid problems, orbit problems. We're going to find those there, and they're all going to be at the start of the chapter. An open bite of the eyelid and periocular area, we don't like that. Puncture wounds with foreign body of the eyelid, those are in the S part of that chapter, and then foreign bodies are in the T part, and we would go back there, and it absolutely would need a 7th character extender. Any injury is going to need that. Holly?
Great. We have a question that we got in our earlier session that might be worth answering again for these folks. Someone wrote, I received an email alert from CMS that they are not going to deny claims if the ICD10 code is not specific. Do we still need to worry about right and left? What about other payers?
So if you listened in before, I'll try not to repeat myself too much, but this was an announcement that came out just yesterday, July 6th, from the AMA and CMS, in which they said that for the first year, CMS wouldn't penalize practices, wouldn't deny codes that were unspecified as long as the code selected was in the right family of codes. Well, this sent all of us coders into a tizzy because ICD-10 codes aren't differentiated into families. They're category and subcategory codes. CPT codes have families, but not ICD-10 codes. So we're trying to figure out what this means. What I believe it means is that they're not going to deny the unspecified codes as long as you have a complete code. So we couldn't use a code that wasn't complete. If we go back to foreign body of the cornea, T15.0 is the subcategory code for foreign body and cornea. It's not complete. And so I think you're going to be denied if you submit that. I think if you went T15.02, foreign body and cornea left eye, you would be denied because, again, it's not a complete code. You would need the 7th character extender X and then the placeholder code X and the 7th character extender, the AD or the S at the end of it. So what most of us are thinking is, they're not going to deny the unspecified codes. What they're going to do for codes that have, for services that have national or local coverage determinations where they typically require really specific codes, I don't know. They say they're not going to deny these unspecified codes, so maybe we're going to be able to get away with them. If I were in a practice, I would be watching really carefully in the first weeks in October for denials, and particularly medical necessity denials or coding denials based on my diagnosis code. And of course, I'm a coder, so of course I'm going to say this. I would be trying to use a specific code to decrease the likelihood of a denial, and I certainly wouldn't assume that any of my private payers were going to go along with Medicare about this. Maybe they will, but I just don't know. So if I hear more about that, Holly, I will certainly send you an email if CMS clarifies that, so you can send that information out to your members.
Great. That is all the questions that we have for today. I want to thank everybody for joining us. This recording will be available and handouts will go out by email by tomorrow. Thanks so much.